Large full thickness macular holes. I mean, one of my first cases more than a decade ago, almost 2 decades ago, was a very close family friend, an ENT specialist. And during the vitrectomy, I somehow caught the edge of his macular hole into my brush needle, and I couldn't wiggle out of it, and the hole did not close at that time, remained open. Large macular holes, typically whenever I have done some flap or something inserted, an inverted flap or just a free floating ILM flap into the area to promote the bridging of the neurosensory tissue, it usually is a healing by secondary intention. So nowadays what I do is what I'll just show you, but probably if we are able to avoid putting any tissue in between, including the ILM, then I think you get a better primary intention healing, and which results in better visual outcomes. Like here you can see the ISOS junction it's almost come back. So is this a repopulation of photoreceptors at the fovea, or what is happening? I don't know. But certainly photoreceptors have come back to the fovea and resulting in good visual outcome. So most of these cases, luckily now we have access to 25 and 27 gauge vitrectomy systems. So most of these cases I operate them with 25 gauge vitrectomy instruments, and being a large hole, the size of the brush backflush, the brush at the end of the backflush needle is smaller than the hole itself. And with that, while I'm aspirating after the ILM peeling is more or less complete, I tend to just massage the edges of the hole. I tend to engage the edges of the hole very carefully without bumping into the retinal pigment epithelium. It's sort of like in general surgery, if we remember, we freshen the edges of any CLW. So it's something like that. And that has been resulting in good closure. So moral of this here, this is another patient where, she's a cancer survivor. She is still on some chemotherapy going on. Had this kind of an RP abnormality on FAF, underlying RP abnormality, as is seen in the OCT also. But we've achieved a good closure and good recovery of vision. So go with the flow and facilitate nature is another important principle. Now this is my own cousin brother. He had a known diabetic. He had come for a routine fundus examination, and I saw a macular embolus. By the time macular branch retinal arteriole embolus, by the time we could get to a photography, it had already passed on. We got a systemic workup done, including carotid angiography. That showed a 90% block. MRA was done, and that was followed by a carotid endarterectomy. Thus, he was saved from blindness and stroke by just one simple observation leading to an entire workup. So, moral of the story, look at the patient as a whole. Often, we ophthalmologists in major multi-speciality conferences, we are all sidelined and put into the corner and so on and so forth. I mean, most other specialists think that we are nothing, chachundar hai ye log. But we can save lives, do much beyond our own limited field. So here was a gentleman with an impending inferotemporal quadrant BRVO. Investigations revealed protein C deficiency, so he's now under treatment with Epixaben, and you can see, although there is a blockage, but before it could become a complete block, the flow has continued, and he's doing well. So put the patient first is the moral of the story. Now, this is a gentleman with a premium IOL whose IOL with the bag got dislocated after almost 12 years of the primary surgery. That's the IOL. So anterior vitrectomy followed by posterior, and here a long 27 gauge needle passed across. Gore-Tex suture passed across. Suture ends drawn out through the limbus. Lifted the IOL. Threaded one of the loops. 25 gauge incision anterior to the place where the original suture has passed. This thread is picked up. Similarly, repeated on the other side. And the IOL was fixed in place. And I do an additional thing a little bit different, that I also take another pass using a 26 gauge small needle through the sclera at the edges of the flap. So that's like an additional anchor. So in case at the base of the flap, in case the suture in the long run erodes through the sclera, there's one more place where it can hold on. So the chances of long-term dislocation are minimized. There's significant striate keratopathy, but it's all cleared off in the post-operative period. So here I had the option of removing this IOL. An easier option would have been just to remove this and do our normal Orolab suture fixated IOL, but managed to do this. Here is a 11-year-old child who underwent primary suturing elsewhere and came with hypotony and pre-thicical situation and defective PL in one quadrant. He had a total detachment with PVR. So he's undergone multiple vitrectomies. Now the iris inferiorly was missing, so I had put in a 40 proline suture to create a barrier and keep the oil back, but that was not happening. So this is the third vitrectomy that I'm doing because there was PVR. So I decided to tackle that along with, so the retina has been attached. I could spare only that much of the macula. This is that previous 40 proline suture which has not been working. This is the corneal scar. It's a corneal scleral scar. And so that's removed. And proline suture passed through. Brought out. Taken through the iris. So on the other side, I couldn't find any iris stump, so just the suture was left behind. So there are two threads of the suture and a little bit of the iris, coming forward, coming into the central area this way, and this has been able to keep the oil back. So moral of the story, think out of the box. The other thing that I do in macular dystrophy cases is I don't just blanket start them on antioxidants. I test them for ABCA4 and ELOVL. If ABCA4 mutant is positive, giving them our vitamin A or analogs in fact will cause worsening. If ELOVL mutant is positive, giving them omega-3 supplements will be deleterious. In fact, will be pushing them downhill. So if these are negative, only then I give them that. Otherwise, I don't give them these. And apart from that, any of these dystrophies, we need to protect them from, even normal light can be toxic. So you need to tell them, I tell them rather, that whenever something can be done by your other sense organs, keep your eyes closed. Our modern mobiles, laptops, TVs, and even movie screens nowadays, they are LEDs as compared to LCDs. So although it's controversial, but the blue light LEDs will certainly have a deleterious effect on the macula. So they need to protect themselves from all these things. And the last thing, for my younger friends, that these are some of the principles with which we have survived all these years, and we've even thrived, notwithstanding. There's no competition other than we, our own selves. So H for honesty, I for integrity, S for service, sincerity, and sacrifice. So these are principles. It was paraphrased this way by Admiral Anand, who was a former Vice Chief of the Indian Navy and a fatherly figure for me. So thank you very much. I'll now go ahead with any questions so far. But can we take the questions after the next talk? So oops moments and diabetic vitrectomy. My first oops moment, something which is indelibly etched on my mind and will remain with me for rest of my life. I'd come back from my fellowship training with Dr. Zivanovich, and I did a beautiful diabetic dissection in a combined tractional rhegmatogenous diabetic detachment. Retina was attached. I had to put in oil, and surgery was superb. It was very copybook style. Next day, however, ये क्या हो गया? बंद हो गया था क्या? So next day, first post-op, it was all extremely beautifully attached retina, clean, clear, this thing. But this is what the patient saw. Patient saw nothing. It was no PL. That was a shocker. Led me back to think. So would you like to discuss what are the causes of such an event? First post-operative day, you open the dressing and no PL. That's normal. It's normal.
But that was the bone. They are gravity assisted, so we always used to keep the bond.
Yes, absolutely. So the even it slipped my mind, and it slipped the anesthesiologist's mind. Normally in our team it's the anesthesiologist who might assign the responsibility of lowering it after 3 minutes or at the most 5 minutes. So the bottle height was not lowered all through the dissection and even beyond, and that was the reason. Absolutely right. Yes.
You probably have to go to that extra level of really lowering them. In the odd case,
Yes.
I don't know what happens. It's the machine, or is an eye succumbing to that pressure is not right for it, that particular eye.
Yes.
So I think looking at the disc is most important, no matter what you said through the surgery.
Absolutely.
But I think in 1995, because we didn't have control, now we have a good control.
No, even then I could have looked at the disc, but through the dissection at the end, when the under PFCL I unfolded the retina, yes, I should have paid attention, but I didn't. Yes.
All operating with valve cannula, so
Yes.
you need to have a look at the disc at that time.
In fact, I believe there was a machine, I forget the name, which would titrate the pressure of the intraocular infusion connected with the blood pressure of the patient on the table. So if the BP went down, they would automatically reduce the infusion pressure and so on. Though I don't, I think it was Reticon who had come, but I don't hear about it much nowadays. Yeah, yeah. So what's the bottom line? The bottom line is, I mean, these are some of the causes of no PL, but the bottom line is that pre-operatively investigate the patient well, and thereafter, I mean, I always tell the patient that there's a 10 to 20% chance that despite a successful surgery, technically successful surgery, vision can drop or be even lost. So I was very, very fortunate, God's grace and the patient's grace, they didn't sue me. Otherwise, I think I would have been finished then and there. The other oops moment was, is this 27 gauge vitrectomy for a recalcitrant DME case, all separation of the hyaloid, everything done, and ILM peeling was completed, and then I was just doing a fluid gas exchange. And when I removed the brush, I couldn't find it on the tip of my cannula. So what do I do next? The needle has come out without the brush at the tip. Obviously, okay, I start looking around, do scleral depression, and put in a wide angle. I mean, first thing I did is just remove the cannula. Sometimes with just the air pressure, if it's just caught in the partially in the sclera, partially in the cannula, it would have come out, but that didn't happen. So I start looking around for it. Didn't find it. Used a wide angle lens to look for it. Didn't find it. So would anybody else have done something else? I just couldn't find the brush. No, it was during the fluid air exchange. So anyways, this has been described in Ryan's textbook, Retinal, by Dr. Karl Klaas. Even he, it seems, lost a brush, but he was very fortunate to have found it, and he was able to remove it. This gentleman, fortuitously or unfortunately, developed a detachment in the post-operative period. I had to go in again, and that's when I found the brush and obviously removed it. So. No, it was by then dangling in the vitreous, yeah. So, sorry?
You should brush the incident away.
I have.
So it's a silicone brush if you leave it inside only.
That's what I thought, but not a good idea, no? Leaving a foreign body inside.
Came back again, but
Yeah.
nothing wrong. I think they don't do anything.
Yeah, they won't give a reaction, but it can cause traction on the remaining vitreous wherever it's entangled. So, best to get it out. So, perhaps if I had an endoscopy equipment, I think that would have been the way to go forward and remove it, or detect it and remove it. I'll be happy to answer any questions now. Okay, I think everyone is famished for a cup of coffee, so thank you very much. Karovi?
Thank you, Paritosh. Are there any questions which you would like to ask anyone? Or I think we are full up with all the lovely videos that you've seen. So we draw this session to a close, and thank you so much for coming in large numbers and attending. Thank you.